We have 5 virtual presentations. This unrecognized cognitive impairment is common in a VA population with peripheral arterial disease, presented out of UCSF by Dr. Eric Smith.
Hello everyone, my name is Eric Smith and I'm a 4th year medical student at UCSF and I'm appreciative of the opportunity to present. We have no relevant disclosures and this study does not necessarily represent the views of the VA. We know vascular patients are some of the most frail and complex patients of any surgical population. And screening for geriatric syndromes is recommended for patients above 65. And one of these geriatric syndromes is cognition. And we know PAD in particular is a risk factor for vascular dementia because of the shared pathophysiology. However, there are no US-based studies assessing the prevalence and severity of cognitive impairment in older adults with PAD. And identifying cognitive impairment in those with PAD may inform shared decision-making around goals of surgery and how it may impact their independence. So the goal of this study was to assess the prevalence of cognitive impairment and its risk factors in a veteran population with peripheral arterial disease, with the hypothesis that cognitive impairment will be common, unrecognized, and associated with PAD disease progression. This was a single institution VA study performed in an outpatient clinic over 1 year. Consecutive PAD patients presenting for surveillance or consultation for a new diagnosis were screened with MoCA assessments by certified personnel and IRB approval. The MoCA is a validated cognitive impairment tool to screen for cognitive impairment. It assesses the various domains that are listed below, and a score of less than 26 out of 30 was defined as cognitive impairment. Disease progression was defined as requiring a revascularization procedure for PAD within 3 months of their MoCA assessment, or presenting with new wounds or wound progression that required intervention such as debridement or amputation. Bivariate analyses were performed for factors associated with cognitive impairment, and a multivariable logistic regression model was performed to assess new cognitive impairment and PAD disease progression with entrance criteria of P of less than 0.1 on bivariate analysis. If there is one slide to take home from the presentation today, it is this slide illustrating that the majority of our sample had cognitive impairment at 61% versus 39%, with 92% of them representing new diagnoses. And there was a spectrum of cognitive impairment, but the majority of our patients exhibited mild, followed by moderate. And those with cognitive impairment were more likely to be older, hypertensive, and have a diagnosis of post-traumatic stress disorder. And while our sample was primarily white, there were disparities noted in that 94% of Black patients exhibited cognitive impairment. Further, we found disease progression to be associated with cognitive impairment as well. This figure illustrates the various cognitive domains impacted by cognitive impairment status. The average score is displayed within the bars, and the delta percentages above represent the percent difference. Now, the most apparent domain was memory, and it is important to note that even in those not meeting our criteria for cognitive impairment, they still exhibited deficits, and that can be compared to something like orientation over on the right, which is scored out of 6, and we can see minor deficits here. And on multivariable analysis, factors associated with cognitive impairment were Black race, post-traumatic stress disorder, diabetes requiring insulin, and age of greater than or equal to 70. And in relation to our PAD disease progression outcome, we found that after adjusting for the variables that are noted in the subscript, cognitive impairment was associated with 3.5 times the odds of PAD disease progression. Now, in terms of our limitations, this was a hypothesis-generating single institutional study performed at the VA, which may not be generalizable to civilian populations or different regions. And given our VA population skews primarily white male, we are limited about conclusions that we can draw in relation to race, sex, and ethnicity. Further, our study was performed during the period of COVID-19, which may impact which patients were seen in our clinic at this time. And lastly, the MoCA is a screening tool which requires further workup to reach a diagnosis and may not be sensitive to capture the entire spectrum of cognitive impairment. Now, in conclusion to this pilot study, we report that cognitive impairment is common in a majority of veterans with PAD surveillance at a single VA clinic, and they were overwhelmingly underdiagnosed. Additionally, we noted disparities in that Black race was associated with 9 times the odds of cognitive impairment. Some of our next steps are, well, at the VA, we have developed a multidisciplinary care pathway for vulnerable patients undergoing vascular surgery, and which has been informed by frameworks from the age-friendly health system, which I'm happy to talk about more, as well as principles from the Geriatric Surgical Verification Program, which is sponsored by the American College of Surgeons. And future research will assess how this impacts care and our perioperative outcomes. And with that, I'm happy to take any questions.
Great presentation. As folks make it up to the microphone, I'll open with a couple questions. Lots to tease out here. The interesting piece to me was that the Montreal Cognitive Assessment demonstrated a higher rate of cognitive impairment in Black individuals. From your other reading, is there concern that there's implicit bias within the test itself that predisposes to labeling people as having cognitive impairment? Has it been validated in that population separately?
So if I can rephrase the question, it sounds like you're wondering if the MoCA assessment has been validated in a population that is primarily Black, and maybe our findings are related to implicit bias. Mm-hmm. I think that is a fantastic question. It is something that is more obvious when you think about people with with limited English proficiency. For people in a Black population, they are primarily English predominant, and so I don't really think this would have implicit bias. However, that is something that in the larger populations of the MoCA assessments has been validated and not necessarily found to be the case.
And then to change gears a little, we know that PAD has a high concordance rate with cerebrovascular disease. Do you think some of the cognitive impairment may be related to undiagnosed strokes, undiagnosed cerebrovascular disease?
Oh, absolutely. Thank you for that fantastic question. That is something that we're actually actively investigating as well and plan to include in the manuscript, like how many proportion of our patients had concomitant carotid disease as well. Given the shared pathophysiology of what we understand with cognitive impairment and our vascular dementia and its risk factors, this is likely to be the case, and this is something that we'll further investigate.
Mr. President.
Wonderful presentation, as always, Eric. What do we do with this? What are the interventions? How do we make vascular clinic better? What are some things we can do? Because obviously these patients with PAD need to understand their problem to want to take care of it, deal with wounds, dressing changes, follow-up, medication taking, So now that we're seeing that so many of these patients are impaired, what's the intervention?
Thank you for the question, Mr. President, Dr. Lee. That is certainly something that we have been investigating further. We think here at the VA, what we have been doing is we've been having a multidisciplinary care program, which is filled with neuropsychiatric tests, geriatricians, as well as primary care providers. We believe that we need to assess for more geriatric syndromes in totality for these patients, and that is something that is hard to do necessarily in clinic. Some clinics may not have the resources, and some clinics may require more personnel. It is certainly an undertaking, but we do believe this is something that is certainly an issue for patients in terms of their ability to adhere to best medical practices, exercise regimens, et cetera. We currently at the UCSF have a prehab PAL, which we are trying to implement at the VA as well, which will tell patients about how their surgery is going to go in terms of getting them prepared. So factors such as having meals prepared, having fall risk removed from their homes and things like that.
One brief question from Dr. Humphries.
Did you look at frailty in these patients also? Because I'm just thinking about this, and where your cognitively impaired patient's a little bit more frail, and then, of course, they need a lot more resources. And I was wondering if you had any way to look at that.
Hi, thank you, Dr. Humphries, for the excellent question. Frailty is certainly something that we do think is important. However, in this study, given the fact that the American College of Surgeons Geriatric Certification Program verification program is encouraging us to move from a framework of frailty, which is kind of hard to tease apart in terms of independent risk factors that are going to impact your patient, to something that's more geriatric syndrome based. Factors like assessing for malnourishment, limited functionality, dysphagia, weight loss, et cetera. These are things that they are encouraging us to investigate. So that's something that we have done in this study. We didn't particularly look at frailty.
Great job. Great job answering tough questions, and your mentors and you prepared you very well.